we shall go on to our last set of speakers, a wonderful topic, and let's all be glued to it. This is about Fuchs with early cataract. And we have Dr. Nikhil Gokhale, who's heads the Gokhale Eye Hospital at Mumbai, and he's going to tell us Phaco only makes sense. And Nikhil has been somebody I've had great regard and respect for over a couple of decades, and he knows about that. And I'm really happy to have him give this talk now. And the other person to contest him is going to be Dr. Pravin Krishna, who is the network director of the Technology and Communications of LV Prasad, and also the director of the Cornea Institute at LV Prasad. And he is going to tell combined procedure is the approach. And the expert view is going to be given by Dr. Namrata and this. So I would look forward to some question being answered by Dr. Shreyash or Charuta following this. And
thank you, Dr. Chitra. Yeah, thanks, Chitra, for the opportunity. So basically, I think when we talk of Fuchs dystrophy, there is still a lot of confusing information which the general ophthalmologist would face with regard to the nomenclature. So we have a very large subset of patients who undergo cataract surgery who have guttata, and we can, just do the cataract surgery successfully and they don't progress in future. The tip of the iceberg is actually patients who have guttata which continue to progress like a Fuchs dystrophy into stromal edema and epithelial and then scarring. So this subset of patient, definitely we have to think a bit louder as to whether we are going to do just a cataract or we are going to do a triple procedure. So this is something that we have to always keep in mind. So if we have maybe 10 patients of non-progressive guttate changes in our cataract surgery patient, we may have probably less than one patient who actually has a true Fuchs dystrophy, which will progress. The next question is that are we or are our ophthalmologists well equipped to distinguish the two entities? That means whether they can distinguish whether this guttate changes is just an isolated event or it's really a Fuchs dystrophy where you're getting corneal edema. And to do that, I think we all have to learn a good slit lamp examination, do specular reflections, specular microscopy, although as I'll show you, it's not very often helpful, and then do a tomography and a pachymetry profile to pick up subclinical stromal edema. This is what was traditionally taught to all of us, that if you have no epithelial edema, if the pachymetry is less than 600, there's no history of morning blurring vision, just do the cataract. And patients where you have epithelial or stromal edema with significantly thick corneas and scarring, maybe you would have to do a combined surgery. Also to stress that patients where the endothelium is poor, they may be very elderly, and if the vision is acceptable, better don't do anything and just leave them alone if they can manage with their vision. And also that severe guttata can itself cause a drop in best corrected visual acuity because of scattering and glare at the posterior corneal interface. How we would see these patients or distinguish these options today is that if we have a patient, we need to analyze them, as I said earlier, and figure out if there is significant corneal edema with a clear lens, in which case you might even consider doing a endothelial keratoplasty alone. Whereas if there is a patient who has a significant corneal edema with a cataract, you might have to do basically a combined surgery. And then you have patients in between where there is no corneal edema, just guttate changes. You need to do only a cataract surgery. And for those where there is early edema, you can still do a sequential or a stage surgery. Now, what are the basic problems that we have when we say that we'll do a triple procedure or a EK, PK with a IOL? We need to understand we have only 1,000 cornea surgeons for our entire country. And if you look at the population which is aging, we have a significant volume of patients. If you look at 2022-23, about 83 lakh cataract surgeries were done. And if you consider that about 5 to 10% of this elderly population has guttate changes, so we had about 4 to 8 lakh of these patients who must have had guttate changes. We don't know how much Fuchs is, but if you in this elderly population, if you even consider to be 1%, then maybe 83% of these 83,000 of these would have had some sort of Fuchs dystrophy changes. We need to understand that only about 28,000 transplants were done in 22-23, many states and districts have no access to transplant surgeries, corneas, and surgeons. And throughout the country, only 4,500 EKs were done in 22-23. And we also have to understand that despite our best efforts, we can still have failures following an EK surgery. So we have plenty of patients, but we don't have enough corneas, nor we have the surgeons to handle all cases of Fuchs dystrophy. So if you are encountering a patient like this, I think we need to look at the age, vision, grade of cataract, stage of the dystrophy, surgeons' expertise, and the access to corneas. So I think the options, if you're working in a setup where there is no eye bank, or there is no corneas, or there are no corneal surgeons, possibly one option is to delay surgery. The other option is to do a careful cataract surgery. And the third option is, if the patient can afford, to refer him to a place where there is a good access to surgery, where they could decide whether they want to do a sequential or a simultaneous surgery. And also to say that a 618 with severe endothelial dystrophy and early cataract may be better than a hand movement due to a failed cornea in a patient who is unlikely to have an access to a transplant surgery. And that's the bitter truth in most rural areas of our country. So if the nuclear cataract is there, vision is fairly okay. One could safely defer surgery. However, if there is a dense cataract, vision is poor, one could do a Phaco with a soft shell technique. However, in patient has got a very hard or a brown cataract, yeah, we can definitely do an SICS. And in those extremely complicated cases, I have no, I would often do an ECC in some of these patients, also to say that the surgeon's experience is a final guiding choice. When you do Phaco, of course, you can use low flow technique, use BSS, minimize energy used, always prefer a hydrophobic IOL with a little bit of myopic target. And I still don't know the role of ROCK inhibitors, whether they really help or they don't help, we don't know. And when you're looking at stage surgery or combined surgeries, it's always, one would say that two surgeries, longer recovery and higher costs. However, the surgery would be technically less challenging. Although in literature, the complications are very similar overall. However, we need to understand that some of these patients in the LVP, only 10% needed a EK 1 to 2 years after cataract surgery, whereas when you do a combined surgery, it's possibly much faster recovery. However, it could be more challenging and difficult. You could have more endothelial cell loss and more graft detachments. And we can have long-term failures over the next 10 or 15 years, which we still do not know. So I think also just to a word of caution that specular microscopy is most unhelpful in these most difficult cases. And that is something we need to keep in mind whenever we evaluate these patients. So I would say assess visual loss, do relevant imaging, understand your limitations, understand the limitations the patient has, whether he can travel, whether he has access to corneas. Talk to the patient, discuss options, counsel, and sometimes masterly inaction may be a good option for some of us. But of course, if you want to do a cataract, use the safest method and the best viscoelastics. And in the very severe cases, of course, do a combined procedure. Thank you.
Thank you, Dr. Nikhil. That was a wonderful talk. So let's hear Dr. Pravin to counter him.
Hi, Nikhil, and hi, Chitra. I think, Nikhil, you spoke for both sides already, and you made the case for both approaches. So, yeah, not much of a debate. And I think at 9 p.m. on a Wednesday, I probably won't repeat a lot of the things. So I'll probably keep it really short with just a few examples about what I'm talking about. So first up, Chitra, as well as the Eye Foundation, thank you very much for having me in this webinar, as well as this interesting format. The debate format seems to be good online, so that the debaters really don't get physical. So you can say whatever you want, but remotely. So I'm going to be speaking about what happens when you have a patient with Fuchs dystrophy and cataract. And just like Nikhil spoke, I'm probably going to be speaking on both sides of the coin as well. And I'll give you some reasons for that too. So when you have somebody who has a cataract, which is greater or is causing more visual disability than the Gaucher and the Fuchs dystrophy, the obvious choice is to do cataract surgery alone. from the perspective of what the patient's need is. And in this case, since the primary need is a cataract surgery, that is probably what you would do. And if you have somebody with more gate, and there are patients even younger who don't have a significant cataract, but then who have more gate and more potentially corneal edema as well, you'll probably do an endothelial keratoplasty as your primary procedure. But the question here is the fact that what happens when you have both cataract as well as gate and Fuchs contributing to the decline in vision, and what you would potentially do here. And Nikhil did give a lot of real world scenarios as well from the perspective of tissue availability and everything else. But I'll talk in a more idealistic sense. If you have somebody with a cataract and Fuchs, you have three potential approaches. One is you can do only cataract surgery and wait for the cornea to decompensate if it ever does, and then refer to a corneal surgeon or do the DMEC surgery. The second approach, actually, which is a quite popular approach that you're not talking about today, is to do only the DMEC and not to do the cataract and wait for the cornea to clear and then do the cataract, with potentially a better refractive outcome in these cases. And the third approach, obviously, is to do a combined cataract surgery with DMEC. And we'll look at what are the upsides and downsides of each of these with some case examples. Of course, if you do a cataract surgery, you probably will worsen the Fuchs and the edema, and eventually the patient may require DMEC. And if you do a DMEC alone, you'll probably worsen the cataract, and the patient will require a cataract surgery in the future as well. So I'm going to show you about 4 cases, and each of these are diverse from the perspective of what I'm trying to show. The first one is a 62-year-old lady. Preoperatively, she didn't have any endothelial cell counts that we could obtain, but she seemed to have quite normal corneal thickness. In fact, her corneal thickness was 492, and we did a good idea to do a cataract surgery alone and not to do DMEC in this case. And so we did a cataract surgery, but a month post-cataract surgery, and it was an uneventful cataract surgery, she had significant stromal edema as well as epithelial edema, and obviously her vision was poor. And when we did the OCT, we also found that the desmoids was slightly thicker, and there were really no areas of detachment of the desmoids, though over the incisions it seemed as if the desmoids were slightly detached. So eventually, this is a case of somebody where we did a cataract surgery in the presence of somebody who has Fuchs, and then it worsened and we required to do DMEC surgery post-operatively. That is scenario number 1. This is, on the contrary, another patient, a 59-year-old doctor, pediatrician who I've been seeing for several years, who came in with a visual acuity of 20 by 25 in the right eye and complained that his vision was not great. So when we did specular, like Nikhil said, the specular wasn't very useful. We couldn't get a count. But when we looked at the topography and the pachymetry on Scheimpflug, there were some of the signs that are described about loss of isopax on Scheimpflug, and his thickness was 555. And then we looked at the OCT, but what was interesting in the OCT was the thickness of the desmoids membrane was quite low. The desmoids was quite thin. So I decided to do only a cataract surgery. And after cataract surgery, the thickness of his cornea really didn't change even 1 month after. So this probably was a good decision from the perspective of doing only a cataract surgery. I'm not going to dwell too much on literature, but again say that literature is again very diverse. It does not give any clear idea about what is a better approach. It talks about the advantages of each approach. So it seems as if what we are looking at is more of a case-to-case basis, depending on what is primary. So again, I won't bore you with literature, but one of the things that is said in literature is the fact that you probably would want to separate the 2 procedures so that you get a better refractive outcome. But here is an example of a patient who had keratoconus with Fuchs, obviously specular, not very useful, and a relatively thick cornea. And you see that the desmoids in this case was also very thick. And this patient, we did a toric IOL along with a DMEC surgery in this patient. And this patient actually did really well with a toric IOL, a very well-aligned toric IOL. And in fact, her visual acuity in the left eye was 20 by 20 uncorrected in this eye, showing that even in cases of Fuchs dystrophy, when you're doing a DMEC, if you spend time with your IOL power calculations, you can actually have very good outcomes. In the contrary, here's another patient who had Fuchs with early cataract. And after cataract surgery, post-op 3 months, she had central corneal edema. And on the OCT, she showed that there was a detached DM with a thickened DM as well. She had undergone desmetopexy twice. So instead of doing a desmetopexy, we did a DMAC. And this is again a complication of those patients where we're doing cataract surgery in patients who have Fuchs. They tend to have a higher chance of DM detachment as well. So what is the difference in these cases? And like Nikhil said, all Fuchs are not the same. And it seems as if the specular is not the best method of assessing who will need cataract surgery and who won't. And for me personally, what I follow is not the Scheimpflug, but what I follow is the OCT. And on the OCT, if a patient has a thickened Descemet's membrane, and what I follow is if the Descemet's membrane is thicker than half the thickness of the epithelium, because it's difficult to measure the thickness of the Descemet's, I will do a combined surgery. If the Descemet's is thinner than half the thickness of the epithelium, about 20 microns or so, I will attempt only a cataract surgery. So again, to summarize what we've been speaking about, cataract surgery only is simple, but the problems are it's likely to need a second surgery, 2 procedures, and also the refraction is less predictable. Cataract surgery with DMAC, advantage is it's a single surgery. You can use the same incisions. The outcomes are very predictable. But the downside is there is a slightly higher endothelial cell loss after you do a combined surgery rather than sequential surgery. So what I follow right now is, again, I won't go into literature, is if I have a patient who has cataract, which is slightly more than the Fuchs, and the Descemet's membrane thickness is normal, then I would do only a cataract surgery. If the same patient has a thick Descemet's membrane, then I would do a cataract surgery with DMAC. On the other hand, if I have somebody where the Fuchs or the edema or the gutte is more than the cataract, and if the patient is young, then I would do only a DMAC and not do the cataract. If the patient is older, where I would think that he probably will develop a cataract soon or doesn't need accommodation, I'll do a cataract surgery and DMAC. Most other cases where the cataract is equal to the Fuchs, like I said again, I will look at the OCT, but in most cases, I will probably do a combined surgery for the reasons that I mentioned earlier. Thank you very much for your kind attention.
Thanks, Dr. Pravin. The talk was brilliant, and really look forward to what Namrata has to add.
I think I have very little to add. Both of the debaters were so elegant, so astute, and so decent that, none actually debated each other. And the topic is also like this, which is debatable, but still has some, guidelines. So I think whenever there's a case of cataract and Fuchs both, as is rightly said, one thing is more important, that is the visualization of how is the visibility, whether you can do cataract alone or not. One point which was mentioned very well by Dr. Pravin, and I'm happy to note this parameter, that you compare the Descemet membrane thickness with the epithelial thickness, and then accordingly you decide whether you would want to do a combined procedure or not. Having said this, if there is a cataract with the Fuchs dystrophy, and if you ever think that you have to do a DMAC, and even if there is very early cataract, I would rather do a combined procedure, because obviously after doing a DMAC graft, you don't want to do a sequential cataract surgery, because you will lose some amount of endothelial cells on the DMAC graft that are there. Another important entity, which I think, I have also seen, and I'm glad that Pravin brought it out, was seen a lot of these cases of keratoconus which have, Fuchs dystrophy, or which have gutte. I don't know whether to call them Fuchs dystrophy or not. And there's a whole series now which we are about to publish. And this is a reality, that many of the ectasias that you have would have, those gutte which are present. Of course, the Sanjay Patel's paper, which has been quoted about the loss of isopax in early Fuchs is there, but I don't think that really can be an indicator, or that really can give you a clue on what surgery you have to plan. So essentially, the parameters which will decide whether you have to do a single stage surgery or sequential surgery would be the visibility that you have, how much you can visualize. Also would be the morphology of the Descemet's membrane in terms of thickness, in terms of presence of guttae, in terms of sometimes the Descemet's membrane is thick and sometimes it is absolutely fibrosed. And I think one thing that has not been touched is DVEC with, phaco emulsification. I don't know, there are not very many studies present, but I'm sure that DVEC, that means the Descemet's, just stripping, or DSO, Descemet's stripping, just stripping the Descemet's membrane and not doing a graft, plus doing a Phaco and IOL, would be equal to, what we do DVEC or DSO alone for a Fuchs dystrophy and allow the cells to populate from the periphery into the center. So that is something which may be tried by people in future. But I think otherwise, all the points have been really covered very well, and there's nothing actually left to discuss.
Two questions I have to all the cornea people here. If a patient with early Fuchs has, not early Fuchs, could be progressive, has high astigmatism, would you put a toric IOL in this patient, because later there is going to be a possibility of doing an endothelial keratoplasty, and the things can change, right? Dr. Pravin had shown one video where he did a toric IOL in a cataract patient.
Yeah, I've done, and I think we've had several cases where patients have had toric IOLs done before in normal eyes, then they had TAS or PBK because of other reasons, even multifocal IOLs, actually EDOFs. And after that, we've been able to do DMEC or DSEC. And I must say that with DMEC at least, and if they're done early enough, then the results are almost the same as you would do for any patient with a normal cataract. So I don't think the potential for undergoing an endothelial keratoplasty needs to exclude them from any toric lens, especially. Premium lens, I wouldn't say yes, because in the presence of guttae, there are more variables with astigmatism and all that. But I think toric IOL at least for sure.
Is there a specific specular count, endothelial count at which you would decide to make a transition, or pachymetry is a more important guide?
No, I think pachymetry probably is the more important. Pachymetry and OCT seem to be the better guide to decide on combined versus single.
I think this was shown also, Nikhil showed pachymetry of 640.
Yes.
The magic figure, and for endothelial cell count, it is generally said less than 500, but we've seen at 500 also the corneas remaining clear. So that is why specular is not, that sacrosanct. And given the fact that specular microscopy can be erroneous, it may pick up from areas, which are not uniformly having a diseased endothelium.
There is a variant of Fuchs dystrophy where you don't get much gutted changes. You just start getting big cells and the cell density keeps dropping. In some of these patients, like I have seen them, encountered them by chance when the other eye, somebody referred for a bullous keratopathy, and then you do the specular and you suddenly find the cornea looks clear, just like a graft with 500 cells looks absolutely clear. These corneas look clear, but when you do the cell density, it's pretty low. So in this variant of the dystrophy, maybe the specular count might guide, but in patients where there are large areas of gutted changes, the cell morphology may not be reliable enough.
Thank you.